Thank you, Eric. Good morning, everyone. Thanks for coming. I want to take a moment to thank Eric for all he does to get this symposium together. This is our 9th annual symposium, and it takes a lot of work to organize the surgeons and get this on the calendar and get our lectures all together and invite all of you. So thank you very much, Eric Nussbaum, for all you do for this symposium and for the New Jersey sports community in general. So evidence-based management of clavicle fractures in adolescents. I have no disclosures to report. When I think about clavicle fractures, I reflect on some of the teachings back when I was training. David Ring and Jesse Jupiter are two famous surgeons from the Boston area who described the clavicle as a relatively agreeable and cooperative bone requiring little more than symptomatic treatment when fractured. A friend and colleague of mine, one of my professors at New Jersey Medical School, could be heard saying, if you want to get into trouble, then fix a clavicle fracture. Finally, skeletal trauma, one of our trusted texts, says primary operative intervention is meddlesome and only makes things worse. And this is some of the teaching that we grew up with a couple decades ago. And then still today in our Monday morning fracture conference, you might hear, well, they all do fine. So you have a 13-year-old male with a football player, has this displaced and shortened clavicle fracture. And you might see that if we follow this over time, we treat this non-operatively and that displacement lessens, it starts to mend, symptoms go away, and over time this remodels. So at least historically, non-operative treatment would do just fine. But the pendulum began to shift somewhere around 2005, 2006, when Mike McKee out of Toronto published this paper, which was a bit of a landmark paper, discussing the deficits following non-operative treatment of displaced midshaft clavicle fractures. They had 4.5 years of follow-up, and they documented residual deficits in strength and endurance which persist after non-operative management. Fracture shortening, which was the fracture shortening up to 2 centimeters or more, was considered that it may be predictive of a worse outcome in these patients. Now, this was a level 3 study. This was right around the time, 2005-06, when levels of evidence were becoming more of the norm, something we talk about in our research and science that we like to follow. Before this, the quality of research, certainly in orthopedics, was not great. There were a lot of level 4 and 5 studies, meaning retrospective, small case series, anecdotal evidence, whereas a level 1 study would be the better quality studies, the bigger studies, the prospective randomized studies. So this was a level 3 study, but it did ask the question, should we be fixing more of these fractures? Soon thereafter, the Canadian Orthopaedic Trauma Society published this paper, which was a multi-center prospective randomized trial. This is a level 1 study. And they compared operative versus non-operative treatment. And their results showed that the patient outcome scores were significantly improved in the operative group. There was a faster time to union, a lower non-union rate, and there were fewer symptomatic malunions. So the non-union rate in the non-operative group was 14%. This was a big number. This was more than we had thought in the past. And this is a number we still quote today as potentially a 14% non-union rate with non-operative treatment compared to the operative group. In addition, the symptomatic malunion rate, where the bone heals, but with a shortened appearance or a bump notable under the skin, that rate was pretty high as well, 18%. And there were complications with operative treatment, some of which needed a second surgery. But this pendulum shift changed the conversation to operative treatment as a reasonable option for clavicle fractures because they may produce a lower non-union rate, a lower malunion rate, possible earlier return to play, possible better function, at the expense of potential for wound complications, as well as the potential need for hardware removal. This is one of those complications here. This is a surgeon and a patient's nightmare. You don't want to see metal peeking out underneath your wound after fixing a clavicle fracture. That's absolutely what we're trying to avoid. So as trends go, once the word got out that fixing clavicle fractures might be the thing to do, the surgical world took off, and the rate of ORIF of clavicle fractures in Sweden rose 700%. And we would follow that as well here in the US and other Western countries. So notable, towards the end of this graph, you'll see that this started to drop off a little bit over in the 2011-12 range. Some additional papers eventually came out questioning this logic. Well, what about in children and adolescents? When this trend started, this was mostly in adults, but as things tend to go, it can spill over into all your patients in the office, including the younger patients in some of the pediatric offices. So let's take a step back and talk about the epidemiology of clavicle fractures in high school athletes. This is a survey from the National High School Sports-Related Injury Surveillance Study. Perhaps some of the athletic trainers in the audience have participated in this, but this is a survey that was an online survey where athletic trainers would document the injury rates of their athletes throughout the school year. And over these 10 years, they documented clavicle fractures and showed us some results which maybe aren't that surprising, but the biggest culprits for clavicle fractures in boys were the contact sports, hockey being the biggest culprit, followed by lacrosse and football. And in girls, it was soccer, followed by lacrosse and basketball. Boys' injury rates were much higher than in girls, and fractures, similar to other injuries, were more common in games than in practice. Interesting, in this study, return to play took longer in those treated with surgery than those treated non-operatively. So treating adolescents and children with clavicle fractures, classically what we would do is either a figure of 8 brace or a sling, and expect excellent results. Operative treatment is reserved for open fractures, which are very rare. Fractures with adjacent neurovascular injury, additionally, also very rare, as well as the floating shoulder, something you don't see too often. That's more of a high-energy injury where there's a displaced fracture of both the clavicle and the scapula, which might need fixation of one or both. But these are very rare. I like to keep things close to home, so there have been numerous clavicle fractures in the Swan family, including my son, a football injury, and my daughter, a soccer injury, and if my third child had a fracture, a clavicle fracture, Dyfus might have been coming after us. So that's how we treated those. But as trends go, a group in China decided to start studying operative treatment of clavicle fractures in children. In 2009, this paper was published. This is a level 4 study, so not very high quality, very low numbers. However, they treated patients as young as age 7 with operative treatment for their displaced clavicle fractures. And their conclusions were that ORIF of clavicle fractures in children appears to be safe and effective. They were starting to follow the adult trend here. So you might question this, and you might actually get booed off the stage in our fracture conference if you had a 7-year-old with this displaced, although not that shortened clavicle fracture, and then fixed it in this manner, which one might argue was not an ideal technique, and then you remove that plate a few months later, that you might argue that that was neither safe nor effective. However, that's where the trend was going, and sure enough, we followed the trends. ORIF of clavicle fractures followed the literature and the trends starting in around 2007. There was a significant rise in the number of fractures being treated, both in middle and older adolescent age ranges. This is from Yang in 2015, Journal of Pediatric Orthopedics. Thankfully, there are some wise pediatric orthopedic surgeons out there who started to raise their eyebrows and ask the question, should we be treating adolescent clavicle fractures the same as adults? We don't treat all our other fractures like we do for adults. So what about the adolescent clavicle? This started to be studied. This was a study by Schultz, who had a level 4 study, so not the best quality, small numbers, only 16 patients. But he compared injured versus non-injured extremities in terms of after non-operative treatment of a clavicle fracture. And they studied strength and endurance and range of motion. They used PROM scores, radiographic scores, and they concluded that there was essentially no difference in the outcome in terms of long-term function. They had a 100% union rate, very important. They did note some mild objective decreases in maximum external rotation and abduction endurance. But this started the ball rolling in terms of what was out there in terms of evidence for how we should treat these fractures. More recently, Pennock out of the University of UCSD studied these non-unions. So the question of non-union was raised because we worry about this in adults. There's a 15% non-union rate in many papers. So Pennock gathered a large pool of data from 8 different institutions to understand why some pediatric patients suffer non-unions and how common is it. So this was a level 3 study, but it had big numbers, and they discovered that the risk for non-union after a displaced clavicle fracture in adolescents is exceedingly rare, less than 1% compared to the approximately 15% in adults. Also very interesting, the risk factors for non-union were really only a previous ipsilateral clavicle fracture. So the usual suspects that we worry about in adults, displacement, comminution, shortening of the fracture, demographics, these are not found to be risk factors in the adolescent population. And then more recently, the FACTS study group was put together. This is the Function After Adolescent Clavicle Trauma and Surgery group. Lead author was Hayworth. They conducted a 2-year functional outcomes study of operative versus non-operative treatment of these fractures. These were displaced midshaft clavicle fractures. This was a level 2 multi-center prospective cohort. They had large numbers, 416 patients, and they only studied adolescents. This was nice because many of the studies out there have a combination of adults and adolescents, and it can be a little confusing. So these patients were followed with radiographs, DASH scores, American Shoulder and Elbow Society scores, and they found that there was no difference in patient-reported outcomes between the operative and non-operative groups. And there was no difference in the non-union rate, which was very, very low, as well as malunion and refracture rates. There were higher complication rates in the operative group, including hardware removal, sensory disturbances, and a variety of other complications. But the refracture rate was the same in the 2 groups, and their conclusions were that surgery provides no benefit for completely displaced clavicle fractures in adolescents. Non-union is exceedingly rare in adolescent clavicle fractures. So you might be asking, why is this? Why is it different? So when we think about clavicles, we got to think about the anatomy. The majority of the fractures are occurring here in the middle third, the shaft of the clavicle. 80% of our fractures are occurring there. However, the physis is a very important factor. Both the lateral and the medial physis play a role in this bone, like they do in all the bones. But the clavicle is the last bone to fuse towards the end of growth. And it does so at a very late age. And so there is still some modest growth occurring in these older adolescents. And we know that the growing skeleton does a better job of healing and remodeling than the adult skeleton. So this displaced clavicle fracture with this pretty significant deformity can heal and can remodel over time. So again, the late closure of the clavicular physes likely improves the union and remodeling rates after displaced clavicle fractures in teenagers. And the FACT study group, which I mentioned just previously, did a nice follow-up study on bony remodeling of clavicle fractures in adolescents, knowing that these bones have a better chance of healing and remodeling. So they did a retrospective review of nearly 100 patients over the course of 3.5 years. And they studied the initial displacement, the shortening, the angulation, and they noted that all of these significantly improved over the course of time. Even these severely shortened and displaced fractures improved significantly. In addition, the longer the follow-up, the more remodeling occurred, even in older adolescents. And those are the ones we're sort of worried about. The 16, 17, 18-year-old athlete who is a lot like an adult and may need to get back on the athletic field very soon. So what about return to play? So often we will say 6 to 10 weeks for non-operative management of most of the clavicle fractures we see at around the high school level. But what does the data say? The data is not great. There's several lower quality studies. Vanderhave in 2010 studied this and described how operative treatment would get their patients back on the field at around 12 weeks versus the non-operative group was about 16 weeks. So there was a slightly improved, somewhat improved return to play time frame. Camachi was a little more aggressive. He described getting athletes back on the field as early as 7 weeks, which is pretty quick. If you dig into that data, it's actually they're allowed to start practicing and being part of the team, but they did not actually get back to competition until closer to 9 weeks. In his study, about 20% of those patients required removal of hardware, and if you're going to do that, then that requires an additional 6 weeks off the field as you're recovering from that surgery. And then more recently, there was a level 4 systematic review of return to play after clavicle fractures. This study found no difference in the return to play operative versus non-operative. So in summary of the data that we do have, ORIF or fixation of clavicle fractures may allow earlier return to play by a few weeks. So that asks the question. So an athlete comes into your office, they're right before their season, what should we do? It can be a tough decision. The trend, both in the media but in the science, was to repair these fractures, although we know from some of these studies I just reviewed that may not be necessary for the long-term outcome. But can you get them back on the field any earlier if you fix a 17-year-old's clavicle fracture? And one way to look at it would be what actually happens. So someone injured, a high school athlete, fractures their clavicle last week. They come into the office this week. And if we choose to treat them non-operatively, then the clock has started a week ago. But if I'm going to treat them operatively, when am I going to do that? Am I going to do that today? Probably not going to happen for a few days, maybe not even until next week. And that's about when that clock starts. So they just lost 2 weeks. So the time difference may not be those 4 weeks that we're talking about. It may only be a couple of weeks. And then you have to ask the question, is it worth it? It may be in certain circumstances. So in summary, clavicle fractures are a very common injury in youth and high school sports. Male collision sports are most common. The majority of these fractures can and should be treated non-operatively with expected excellent results. The non-union rate is exceedingly rare in young people. The clavicle remodels later than other bones, including in older teens. It grows up until about age 25. So the later teens probably do have a chance for remodeling and healing in these fractures. Return to play is 6 to 10 weeks. ORIF may accelerate this and be indicated in certain circumstances. Here are my references, and thank you very much.